So now without further delay, let's begin today's event, sponsored by Imprivata and hosted by Health Data Management. It's my pleasure to introduce your moderator for today, and that is Mike Perkowski. Mike, you have the floor.
Thank you very much. Ladies and gentlemen, we're glad you could join us for today's program. As you heard, I'm your moderator, Mike Perkowski. This program is hosted by Health Data Management and sponsored by Imprivata. We want to thank Imprivata for their support for this program. We do appreciate that. Obviously, this is not only a very timely topic, it's an extremely important one for many reasons, and our two speakers today are going to cover some of the specifics on how to look at this topic and, most importantly, how to achieve the goals that hospitals and healthcare organizations have around this. Our first presenter today is going to be Dr. Sean Kelly. Sean is the Chief Medical Officer at Imprivata, where he heads the company's clinical workflow productivity team, and he advises on the clinical practice of healthcare IT security. In addition to his role as the CMO at Imprivata, Dr. Kelly practices medicine and teaches at Beth Israel Deaconess Medical Center, a level 1 trauma center, an academic teaching hospital in Boston. We're glad that we have him today. He's going to be joined by his colleague, Aaron Meary, who is the Chief Information Officer and Vice President for Government Relations at Imprivata. He's held leadership roles in healthcare IT for more than a decade, and most recently as a provider healthcare system CIO. In his role, he is responsible for leading the vision, development, and implementation of information technology initiatives in support of Imprivata's overall business plan and strategic vision. He also continues to provide active thought leadership in healthcare IT security to help inform and drive public policy in order to ensure cybersecurity and interoperability become a reality in healthcare. With our two speakers today, we're fortunate to have a wealth of knowledge. What we're going to try to do, in addition to the traditional presentation format, we're going to try to make this a little more interactive. We're going to have it as conversational as we can. I'll be posing a series of questions to our two speakers. So with that, I'd like to turn the program over first to Dr. Sean Kelly. Sean, the floor is now yours.
Thank you. As was mentioned, I'm an ER doctor as well as being the Chief Medical Officer at Imprivata. So I'm going to put my doctor hat on for a little bit of this conversation. We're going to talk today about why electronic prescription of controlled substances matters in the setting of a terrible opioid epidemic going on in this country right now, which is a public health crisis, and I see the effects of really every day on shifts in the ER as well as attempt to curb through technology and our work that we do with provider systems around the country. There are several drivers of adoption that we're going to take a look at and explore, both touch on in the initial conversation and probably do a deep dive on in our discussion and question and answer session. And that's really going to be the root of most of this webinar. Is really Aaron and I are going to talk about how both IT as a department and clinicians can work together with their community and their pharmacies and other resources to combat this epidemic and really help both from a patient safety standpoint and a financial standpoint. So why does this topic matter? Well, as we said, right now there's an incredible crisis going on in our country and really around the world. Unbelievably, prescription medication overdoses and narcotic overdoses, controlled substance overdoses, actually kill more people right now in our country on a daily basis than car crashes. That's not because we're safer drivers. I know from driving around the Boston area that we're not safer drivers, but technology and regulation have come into play to make driving in cars safer. This has not yet happened with regard to prescribing controlled substances, but just like in the case of trauma, there actually are regulatory and technology advantages that we have and products and technology coming of age that can help actually combat this public health epidemic. So right now, the way things were done for a number of years, was that doctors and nurse prescribers could electronically prescribe medications except for right when we needed that system the most with controlled substances. So up until recently with the DEA, really doctors and nurses that are prescribing were using paper, and this is a vulnerable system for many reasons. Vulnerable to fraud. Up to 10% of us have our DEA number stolen and used for drug diversion and abuse. Very inefficient workflows. If you think of, for example, a patient and their mother who may have to go fill medications for ADD or ADHD, which are oftentimes controlled substances, every month that patient would have to come in, or the parent would have to come in, actually physically pick up a paper prescription, take it over to the pharmacy, hand it into the pharmacist, and wait while they got it filled. Not very much of a patient satisfier, really frustrating for both provider and patient. And it's an inefficient system. Now that we have technology that we're able to use for e-prescription, we really want to use it in the cases where some of the most powerful and yet most dangerous drugs that we have, such as controlled substances, we want to use it in that efficient workflow that's both a patient and provider satisfier. We want to use it in that case too. There are meaningful use regulations, and many of them, people and providers and healthcare systems actually get incentivized to hit meaningful use criteria with percentages of e-prescriptions that are done electronically. And while you can throw out and discount the ones that are controlled substances, actually an increasing number of controlled substances are being prescribed in this country. And data that we've seen shows that almost 60%, so 58% of people being discharged from a clinic or a hospital actually have at least one controlled substance. And in those cases, the workflow often defaults to the one that's able to be done for that one particular medicine or two medicines, and then all of the medicines are actually printed or handwritten rather than done electronically. And those other several medications may not be controlled substances. Therefore, they are included and count against that hospital system or provider as far as the meaningful use numbers. So there are a number of prescriptions at risk for meaningful use, not just the narcotics. Narcotics are right now approximately 13% of the prescriptions being written. But when you realize that up to 60% of patients being discharged and sent home actually have one controlled substance, those are a lot of numbers that count against you in meaningful use if you're trying to hit those metrics. So we talked about just the pure numbers, and they really are staggering. I believe it was 2014 was the last year that the CDC, we have data, over 400 million prescriptions were written for controlled substances. For 400 million pill bottles sitting out there in medicine cabinets around the country, in the U.S. alone in one single year, that's 2 pill bottles of controlled substances out there that are available for people to get a hold of, get addicted to, divert, and abuse. So for many reasons, the old system is complicated, it's fraught with abuse and fraud, it's limited, and therefore now we're looking to move to a better, more technologically advanced solution. So there are regulations now starting. Several states have actually mandated that not only is e-prescription of controlled substances legal, as the DEA said it was in its interim final ruling in 2010, but actually it's required. And so New York was the first state to do this with the I-STOP mandate, took effect in March of 2016. Maine and Virginia have followed, and actually just this week, Connecticut has also passed a law so that starting, I believe it's January 2018, all prescriptions there must actually be electronic as well, including controlled substances. We see a number of states that are looking to pass similar mandates, so there are regulatory factors coming into play now where many healthcare systems and healthcare providers are going to have to be electronically prescribing controlled substance just to be compliant and in their prescription processes. So I think at this point we're going to take it to a question and answer session and discussion with how to really establish a successful partnership between IT and the clinical staff.
Okay, so this is a time for a good, discussion with Aaron and Sean. So Aaron, we'll start with you. How can hospitals establish that partnership between the two, and who should be on the EPCS team in order to ensure the successful implementation? What roles do they play?
Yeah, no, great question. So first and foremost, I think from an IT side, I'll speak towards, every CIO, IT administrator on this call knows that in order to be successful with your clinical partners, you really have to adhere both in practice, in the way your discussions, in partnership, with really leading with that, Stephen Covey principle, seek first to understand before being understood. You really have to listen to your clinical partners, understand their workflow, get into the clinical areas, shadow, watch where they prescribe, watch how they prescribe, from what modalities they prescribe from, and make sure you do your homework. I have done this implementation enough times in previous lives that I've seen it go well and I've seen it go sloppy. And every time it went sloppy, it was simply because the homework wasn't done up front. So first and foremost, take your time, listen, observe, watch, and watch the interaction with the patient. See how the patient, receives their scripts, what questions they have, how they go about, figuring out what pharmacy to go to, when they have questions for the physician for follow-up upon discharge, looking at the discharge disposition and instructions when they're leaving to figure out what meds they're supposed to be taking and how often. All those things matter. So that's first and foremost. Make sure you do your homework. Number two, work with the physicians, work with the clinicians, work with the PAs that are actually prescribing, and understand at what point during the course of care do you prescribe? Is it up front? Do you automatically know? Is it after answering a number of questions and looking for med allergies? Is it upon med reconciliation that you do this? Those gate points are very, very important, because the way a physician prescribes in the ED is very different than the inpatient arena upon discharge, and very different in an ambulatory setting. All those things absolutely matter. Number three is really making sure that when you look at vendors out there and looking at what solutions are configurable, that you make sure that you have one that works with the clinician workflows. Don't try to smash a square through a round hole. It's never going to work. You have to find solutions that are malleable and that work well, and there's ones that are out there. Greg, you asked who should be on the team. Truly, first and foremost, it takes leadership, right? It takes IT leadership, it takes clinical leadership, it takes hospital administration, it takes everybody. Number two, make sure that your EMR administrators, from your directors of clinical informatics all the way over to your clinical EMR administrators, are all involved. They have to be able to explain to the doctors where in the EMR in the course of care they'll be prescribing and how they'll be prescribing. Will they be using a fingerprint? Will they be using some other modality? Those things matter. And last but not least, make sure that you involve, if you have a clinical informatics team, you involve them up front. They are your greatest ally in this whole process. It's not hard. It's not difficult. Just getting the workflow right is what matters the most. Sean, anything you want to add to that?
Yeah, I would echo that, Aaron. Workflow is king in the clinical world. Doctors, patients, nurses, everybody cares about how they can do their work and focus on the patient. All the things that Aaron said about learning exactly what that workflow is and making sure that in the electronic world, you're not breaking that doctor or nurse prescriber out of a workflow they're used to. So in other words, does whatever technology you plan to use for EPCS, can it integrate directly into that EMR, e-prescription writing module? So for me as a doctor, when I'm in that system and I write for a non-narcotic and I hit OK and that gets sent out electronically, if I do the same thing and there happens to be a controlled substance in there and I hit OK, what happens now? For me as a clinician, I want it to look and feel virtually the same, except now by DEA guidelines, I'm going to have to authenticate with two separate modalities. The DEA is very strict about what I'm allowed to use as a clinician and very strict about how I'm credentialed in and enrolled, and all the hardware and software that goes into that has to be DEA compliant. So if that all works seamlessly and is invisible to me as a clinician, when I hit OK to that order that includes Percocet, and it doesn't take me to a whole separate window where I have to log on again and go to another separate thing and re-look up a patient, every one of those potential areas is a delay, is a break in my concentration, and another potential failure point. So integration of the technology, whatever the authentication software and hardware is, as well as the credentialing hardware and software that goes into play behind the scenes, is crucial, because if I don't see any of that and it just says at this point in my workflow, me as a prescriber, okay, put my finger down or use this token system on my phone, and I can do that in a few seconds, that's actually quite painless for me, and even better, because now I don't have to write out a prescription with my terrible doctor handwriting that barely anyone can read, including myself, and put my DEA number on it to give to someone to go walking around in the world with my DEA number on it. So from both a security perspective and a convenience perspective, having IT working closely with clinical leadership, doctors, nursing champions, even people from patient experience, to understand what is the effect of this workflow on that patient, what is the effect of this workflow on the end user, specifically the prescriber and the people who have to help get that patient home safely and go to get their medicines. So who should be involved? Along the line of what Aaron said, any clinical champion can be valuable. I think nursing and nurse managers, don't neglect them as very powerful influencers on how workflow really happens in the hospital and the clinic scenario. They know what it takes to discharge a patient and what has to happen as far as selecting pharmacy preferences, where prescriptions may print or be channeled electronically. Issues like, is it a 24-hour pharmacy you're sending them to? I work in the ER, right? So, I may plan on discharging someone at 2 o'clock or 3 o'clock. If their ride shows up at 5:30 after their pharmacy closed, you have to account for that in the workflow. There are ways to do this. It's not rocket science. You just have to know and think about and do a lot of contingency planning, same as you do for paper discharges. It's just a similar process. It's just there are different variables involved. Any vendor you use, any technology vendor, hopefully is savvy to this. I know that we have a whole team of clinical people and clinical informaticists that work with our security and IT experts on the vendor side to also work with the same experts and the same types of people on the provider side, so that we all work together as a team. I can't emphasize that piece enough. Pharmacy is often involved, pharmacy leadership and pharmacists. And then, the legal and compliance office and credentialing often get involved, although I will say one of the common things that we see is that the DEA uses, in the regulations, uses the word credentialing a lot. And in medicine, we think of credentialing as how we credential our providers to be able to practice medicine in a particular state or at a particular hospital. So it's not exactly, it doesn't have to be the credentialing office that does a lot of these things, and we're going to talk about how you credential providers for EPCS, but it doesn't have to be someone in the credentialing office per se, although you can work with the credentialing office. People in IT and people in certain clinical departments can actually perform that function as defined by the DEA. That's just a point of confusion that we often see when we're counseling and partnering with our hospital systems, is that word credentialing is used in many ways, and it's not the typical way that our healthcare systems uses it. The DEA very specifically means how do you enroll people into the EPCS prescribing system when they talk about that.
So policies are obviously very key in this. There are many issues. Sean, can you talk about some of the key policy decisions that the team needs to think about before they move to an implementation?
Yeah, absolutely. There's several levels, right? There's federal regulations, which are the DEA regulations, and all of the different stipulations of this discussion. It starts with that. So every technology that we're talking about and all the personnel and the policies at the state level and at the hospital or regional level all fall from that. They all have to be compliant with the federal regulations put forth by the DEA in order to be compliant and legal, to be able to have prescribers electronically prescribing. That said, there are policies at the hospital level that people want to be aware of. vendors like us, we create systems that try to make it as easy as possible, but ironclad as far as not letting anyone do anything that's off of policy, that is out of compliance. And when audited later, we make sure that it all follows the federal policy, whatever state policies are in that area, and then whatever regional policies are put into place or policies at the hospital level. As far as that, what that means, well, first of all, who's going to be allowed to prescribe? In general, most hospitals will look at this and say, well, who's allowed to prescribe on a paper sheet? And that list is generally the same list of who you would like to enable to prescribe electronically. Questions often arise. Attending physicians, full-fledged attending physicians with their own license, who are fully licensed, credentialed at that hospital in that state, generally, there's no question they're generally allowed to prescribe, just like they are now. They often have their own individual DEA number. But questions arise around, for example, at academic institutions, do residents and interns, do they have the ability to prescribe? And the answer is yes. It is legal for them to prescribe. They often use an institutional DEA number, and they often have a suffix after it. But they can prescribe just like they can on paper. Mid-levels as well, if nurse prescribers legally can prescribe within that state, then yes, they can be enabled as well. The key question in the electronic world is whoever is actually writing that order in the electronic medical record, whenever they go to authenticate that order and hit OK, if it has a controlled substance in it, we are going to check against our database to see if they have been properly credentialed and enrolled into the system and have permission in the EHR as well. And if so, then that prescription can be authorized if there are 2 factors of authentication at that point that are given, and then it can be routed via SureScripts to a local pharmacy, retail pharmacy. So those are the policies that are in place. You can break them down into several different categories. One is, how do you onboard these providers that you're going to have prescribe? How do you credential and ID proof them? 2, how do you enroll those credentials into the technology, into the electronic system? And then, the 2-factor authentication, for me as a doctor, that's actually the most important workflow issue. You only enroll once, but you authenticate thousands of times, right? So the enrollment process, while it can be difficult, is a one-time thing. There are certain techniques that can be used by good technology vendors that make that a heck of a lot easier. And again, we can do a deep dive on that. But the 2-factor authentication process that the DEA says, at the time I prescribe, I need 2 factors of authentication. And I think we're going to maybe walk through that separately because it's such an important topic. And then keep in mind that all of this stuff needs to be audited and reportable. And so having a software system that does all of that stem to stern is crucial, because if it's up to the provider system to try to create a bunch of their own home-built disparate systems to keep track of this, you actually have to make sure that it's all been certified as an entire system stem to stern, so there's no holes in that. Because really the DEA wants a fail-safe track of authenticity and ironclad guarantee that whoever was onboarded and wrote that prescription, there's truly an auditable, reportable record to that. And so that's why having a comprehensive system that includes each of these things is really key. I mean, technology, for example, that only will work if someone has properly enrolled their fingerprint, and that fingerprint reader that's plugged into the endpoint at that point actually is FIPS compliant and DEA compliant. And it can't be spoofed by putting in a non-compliant reader, or it can't be spoofed if someone else put their fingerprint in instead of you, because it's a witnessed signing procedure to credential them. So those are small examples, and maybe I'll open it up to Aaron and see if he has any more comments, because we could talk about each of these things for hours.
Good, and it's really important though, Sean. I think number one thing that you touched upon that I want to reemphasize is make sure that you understand the process of institutional ID proofing. How does your institution today credential and give the nod that a attendee, a clinician, a mid-level can prescribe meds, right? Is it an institutional ID? Is it, their own personal DEA number? What is it? I'll tell you, in a previous life of mine, we were a teaching facility. Therefore, at any given time, I had new groups of residents rolling in and rolling out. And getting ahead of that and making sure that they were ready to go in the EMR, making sure that they had permission to prescribe in the EMR, making sure the order sets were things were prescribed automatically based upon condition and of care, and they could just sign off on the order was set to go. All those things had to be done in advance. So truly understanding that is very important. Number two, exactly what Sean said, make sure you select a technology that absolutely is FIPS 140.2 compliant. Go for technology that the vendor has taken the extra step of getting certified by the DEA. You can actually get a letter from a third party that states that you are compliant and you've met those. Ask for that. Make sure you ask for that. It's very, very important because the last thing you want is for there to be some sort of diversion and you get a knock at the door and suddenly they're like, show me the paperwork, show me your due diligence. And you maybe went with a different route and you shouldn't have. Those kinds of things are very important up front. Another thing is, making sure you identify up front how you're going to enroll the clinicians, partnering with them to make sure that you walk through the process and of how to enroll in the two-factor technology is very important. It's very easy and seamless, but if you don't take the time to explain to them and go within the setting of care and those sorts of things, it can really trip you up. And then again, I can't stress enough, and it saved my bacon several times with auditing and reporting. Having the robustness to be able to pull reports and show, just as a pharmacy director would pull wastage, right? To pull who prescribed what drugs, when, what frequency, to make sure we're not overprescribing opioids and other types of drugs is crucial. You're going to get those requests, you're going to get those questions and answers, and it's very, very, very important it all matches up. So I really just want to emphasize what Sean said from a clinical perspective. The IT systems must match up to that, and it's incumbent upon you to take your time and do your homework. Don't just go with someone's word. Ask for the proof.
Okay, so the issue of identity proofing and the whole enrollment process has obviously been touched on here, but let's see if we can dive in a little bit more. Aaron, do you have any tips that you can share with the audience for a successful identity proofing and supervised enrollment process?
Yeah, so a couple things have been in previous slides. Number one, as I said a little earlier, making sure that you partner very closely with your credentialing office, medical staff affairs, whomever's doing that in your hospital or hospital system, and really understanding what they do today is very important. So that's number one. You must upfront partner with them. Also, I always partner with compliance and made them aware, hey, this is going on, this is what we're doing, this is why we're doing it. So getting those stakeholders to the table up front and explaining to them before you even engage the clinical champions is very important, so that as the clinical champions have questions, each of the teams can answer specific questions so you can partner together. And then really as you're going through and starting to do identity proofing, you have to figure out, as an institution, are you going to do this? Are you going to roll right into what you do today? Or are you going to go and try to leverage technology where you can individually proof the clinician and they could do it from home? Maybe they could use some personal piece of data to be able to prove who they are on the side. There's technology out there, we do it, and others do it, that allow you to do those kinds of things. So it really is a couple of institutional decisions up front that need to be made, but it all takes understanding, patience, and awareness and communication. Again, one of my previous slides where we had, hundreds and hundreds of new faces that were prescribing, every couple of months through rotation, we chose to go the institutional route because it was just very arduous and it was something we wanted to do and get a hold of. But other institutions I've been at have done the individual identity proof, and there's no better way to do it. It just depends what your workflow is. Anything you want to add to that, Sean?
Yeah, I think it's important to realize that, again, around this credentialing issue, some technologies allow, you don't have to necessarily send everyone to the credentialing office, because if you go ask the credentialing office to take on a new duty like this, they're going to push back pretty hard a lot of times. Good systems should allow and the DEA allows people to be given administrative privileges to do this. Several in your hospital can be given that. So people in IT, people in clinical departments that are informaticists, they can actually have the privileges allowed on the software system to actually perform this supervised enrollment. The DEA is very specific. There need to be at least 2 individuals that participate in this that have to be from different departments. One can be someone who does this supervised enrollment, and the other one grants the access control where the permissions are looked over within the EMR, and people then are given the permission to prescribe in the EMR system. And those things don't have to happen at the same time. Those processes can happen asynchronously. So in other words, you can have the access control piece where a list of eligible people can be given to someone with a laptop, and with our system, that someone with a laptop, you can actually go to the clinicians. There's no better way to do this rather than having them all have to try to get all your surgeons and your hospitalists and your ER doctors and your residents to go to the medical credentialing staff office. Rather than doing that, you go to them at grand rounds, you go to their physicians meetings, you go to the physician lounge, you go to their major ambulatory site. For the surgeons, you can go kind of at 6:30 before their 7 a.m. surgeries. You go sit in the pre-op area, and you can just sit there and enroll them. And what that involves essentially is identity proofing and credentialing them. And so you will actually have someone from your place sitting down in front of a laptop who will go up to Dr. So-and-so, check some sort of an ID and checkbox into the system that you did that, and then actually have that person sign into the system so you know it really is them, and then enroll their finger or give them a token that they can use subsequently when they're prescribing. And so this is not there are multiple steps required, but if you have technology that actually eases that burden and allows you to actually go to them in places where they are already captured in their work, there's no better way to try to get a lot of people onboarded quickly than that, rather than trying to have them go through a process that's onerous for other staff in your hospital and for them as well. The DEA made this intentionally a high hurdle because they want to really make sure that there are at least 2 people signing off electronically that this person really is who they say they are as a prescriber. They've been ID proofed and credentialed, and then the access control is not in the hands of that same administrative person. There's a separate person in your system that grants them access to the system to prescribe. So what the DEA has done is essentially said, look, there are 2 separate individuals at the hospital level who are signing off that this person really is who they say they are as a prescriber, and their finger and their token really correspond to them, so that later in the system when they prescribe something, there's no debate that Dr. Sean Kelly really did write that Percocet order. That's the point of it. And the whole idea is you have to have a technology that makes the easy thing also the compliant thing, and vice versa.
Okay, let's go on to our next area. Hopefully by now our speakers have done a great job in establishing the need for this kind of a solution. But let's talk a little bit about what the key considerations should be when actually evaluating and selecting a solution. Aaron, what are your thoughts on that?
Yeah, thanks for the question. I think this is a very important question, and I go back to sort of the theme of what I've been talking about all afternoon now, which is you really have to select a solution that works well for your workflow. Look for a solution that truly has different options for authentication. Do you have hands-free ability? Do you have the ability to use fingerprint? What are those FIPS 140.2 compliant workflows that you could bring to bear for your workflows within your institution? And really making sure that, you're not trying to fit a square through a round hole. The juice isn't worth the squeeze if you're having to do something more than what feels organic for the institution. And your clinicians have to be part of that process. I can't tell you how many times I brought 2 or 3 different kinds of solutions to the doctors and said, hey, you guys and gals, try this out. Tell me what the feedback is. You be part of the choices and selection process here. Bringing in clinicians up front during that technology selection process is invaluable. Some of the clinicians will tell you, you know what, I don't care. I just want to work well within my workflow. Some of the clinicians absolutely want to try it out. It's like, hey, I want to try out the car before I buy it. So don't be afraid to engage the clinicians up front in that process altogether. And then also look at, security requirements. In today's age, unfortunately, there are too many very crafty bad guys out there, and drug diversion is such a big business, unfortunately, for this country and other countries, that you can't take any chances. So make sure that the solutions you look for have the ability to be completely, thoroughly vetted, are, again, secure, they meet the NIST standard, and that they are been vetted in a marketplace, and they're proven solutions. So, looking at, again, the workflow, really making sure that it has extensibility from a solution perspective, again, making sure that it can be malleable to the workflow considerations of the area. And then, as I said, lastly, the compliance with all the highest standards of care, as well as security provisions. All those things matter. Sean, you want to add to that, please?
Yeah, I would add one note of caution. There are a lot of token vendors out there. The token is one of two factors that a prescriber needs in the EPCS process. So while a token solution, a token-only solution is DEA compliant, it only is DEA compliant for one of two factors that you need as a prescriber. The credentialing, the auditing, the reporting, the access control, a number of other things. It's not necessarily you are on your own convincing the DEA that you were compliant with all those other things if all you're doing is getting a token and adding that into your usual workflow. So just be careful of that. Look for a letter from a third-party auditor saying the whole solution stem to stern is compliant. Make sure you actually read those DEA regs and know what you're required to do from the credentialing and enrollment, identity proofing, and access control and auditing and reporting piece if you don't have a comprehensive solution. So by comprehensive solution, I'm referring to a comprehensive EPCS solution. What we've done and maybe some other vendors have done is realize that if people have tokens on their phone, you can leverage that same token technology for other things like remote access. So if I am at home and I'm logging in to finish my chart and I already have a token on my phone, my hospital system can have me use that as a second factor authentication to prevent things like phishing attacks and people getting my email, my address, getting my password and then using that as a single factor to get into the network. By having that second factor and requiring something like a token access, you're preventing a lot of network breaches and the cybersecurity issues that are happening in this world right now as Aaron said, in healthcare. They're only going to get worse as the sophistication increases. So being able to leverage the same technology for things like remote access, or even in our case, the ability to use that same software platform that exists for not just EPCS, but for single sign-on to be used for things like clinical workflows where you have second sign-on processes within the workflow for witnessing, med wasting, when you're ordering high-ticket medicines or you're going against POE recommendations, having a second factor authentication placed into the workflow there is an example of ways to leverage the same technology. And look, because it's so strict and so high level to meet DEA requirements, then it's actually pretty easy to turn it on for these other less stringent requirements that actually make sense in healthcare. And if you should be able to discuss with whatever vendor and with other places that have used it, how you can enable that similar technology and get the most out of the platform that you put in.
Yeah, and one more thing I'll add to that, Sean. What I always did also was partner with my electronic medical record vendor and ask them, who's the preferred player in this space? Who is the go-to for doing EPCS? And they would point me to the right person. And don't be afraid to ask questions. You don't have to go it alone. There are a number of, obviously, states under mandates, states about to have mandates. So hospitals left and right are going this route. There are folks to reach out to, reference sites, ask for all of those. Again, I was saying it earlier, don't just take someone's word for it. Go do your homework. Look into it. Make sure you select the right solution and select the one with the best, satisfaction, clinical satisfaction at the end of the day.
Okay, so for solutions like this that are becoming increasingly important for the healthcare organization, implementation is a big, big issue. So, Aaron, where do you see some of the biggest roadblocks when implementing this type of solution, and what do you suggest in order to head off the problems before they occur?
Yeah, I think good question. So I've been talking about this a little bit all afternoon. It goes back to workflow. So number one, the biggest roadblock I've seen, again, where things go poorly, is simply not doing your homework upfront to understand, really not doing that due diligence, and not really understanding, how do workflows work today, or is there a need here to really reevaluate the process? Remember, being a CIO doesn't mean you just go select a technology for because you want to. You select a technology that matches up to the written process. At the end of the day, you have to ask the question, what would you do today if your power went out and you're back to pencil and paper? So you have to have your process clean. You need to understand what's going on. So it goes back to asking the right questions. Number two, really making sure that you understand the technology that's being brought to bear. Selecting a technology that is maybe the lowest cost is not the right thing to do, because you'll miss being potentially FIPS compliant or DEA certified or having the right modality that works for your workflow. So make sure that you understand truly what it is you're buying and what you're trying to do. And then, as I mentioned before, the clinical champions are key. You've got to partner with your clinicians. You've got to understand, and you've got to have them part of the buying process. That's key. Otherwise, you're going to be ripping out the solution in 6 months to a year and putting in something that does work, because the clinicians will not put up with it. Prescribing meds is such a routine and common activity that if you impede that or delay that activity, you're adding minutes, if not hours, to the day of a clinician, and they're being asked to do more with less every single day. Sean, anything you want to add to that?
No, I would echo the fact that the workflows are key. We've kind of, I think, hammered that point home. Just make sure that you're not trying to introduce a suboptimal workflow. You want to make sure that token systems, maybe some fingerprints in certain areas, fingerprint readers would be very helpful. Just be cognizant, like Aaron said, within the parameters you're able to work as much as you can with clinicians to understand how we're not going to interfere with their workflow as best as possible. I think interacting with local pharmacies is important too. 85+% of pharmacies are enabled for EPCS. Many more pharmacies are ready to go compared to provider systems. But that being said, it still requires some time and effort to actually go ahead and communicate with them, so that when prescriptions start being routed through, the manager at the front desk at that time, at 8 o'clock on a Friday afternoon, really does know that it's okay to accept that. In fact, it's preferred to accept that. So that's sort of another sort of fine point. Just make sure you're communicating with your local pharmacies. I will say this is actually an opportunity a lot of times for hospitals to channel prescriptions to the pharmacies where they'd like the prescriptions to go, where maybe they have a better communication with them. And the ability, like that some hospitals even have retail pharmacies that they help staff and they help run, that are more on formulary and have a better channel of communication if there's any issues around filling a med or a dosing question, things like that. So this is actually an opportunity to examine your workflow and make sure it's the right thing. Also, I would be careful again with your own compliance office and your own credentialing office, and really emphasize, sometimes compliance officers start looking at these regulations and get very resistant to putting a system in place, and I would make sure that you emphasize that these providers are prescribing right now. They are prescribing controlled substances right now. It's just on paper. And so anybody who's allowed to prescribe right now on paper should be allowed to prescribe electronically, as long as you use a system that's compliant with the DEA regulations, and vendors like us guarantee that piece of it. So it shouldn't be that you're now rethinking having to re-credential every single provider and recheck all of their documentation in every single way. It just has to do with the extra step of ID proofing them and attaching them to a token or a fingerprint.
Sean, you just talked about the vital role that the pharmacies play in this whole process. Can you go into a little bit more detail about the best ways to communicate with pharmacies in the area before you go live?
I think I would just reemphasize that we had said, really before you go live, take the time to call the 5 or 6 major pharmacies around you. Many times if some other hospital system or practice near you has already done this, you're all set. But if you're the first in a particular region, literally just call and have your pharmacy talk to their staff and just say, are you enabled? Chances are the answer is yes. And if so, put a little memorandum out, have them have a little notice in an email and a session with their own staff so that the people that are actually on duty know what to do when the prescriptions start coming through.
Okay, so let's talk for a minute about the specific DEA requirements for EPCS.
Yeah, so real quick, I'm gonna go through this a little fast because of time. But number one, the DEA requirements are pretty arduous, so I'm not going to go into extended detail about that. I encourage everybody to go read those and understand them directly. But real quick, making sure that you understand, as Sean said earlier, that what two-factor authentication actually means. Just having a token does not meet two-factor authentication. Making sure that there's EMR certification, pharmacy certification, adoption by the State Board of Pharmacy, and really understanding truly how there's an audible chain of trust. Any solution you select has got to really be able to identity proof the individual that is prescribing, have the access control there, the two-factor authentication we talked about, credentialing enrollment, which we talked about earlier, and of course the auditing and reporting. The whole process is extensive and very, very in-depth. Partnering with the right vendor makes it very simple and very seamless for the clinician. So I'll leave it at that and just encourage you to look at those regs and make sure that you select a solution that works.
In my opinion, this slide actually captures just about everything you need to know about the DEA regulations. And so, the slides will be available to you, and we're happy to answer follow-up questions. You'll recognize a lot of the terminology here. We've done a deep dive on several of these, and we're about to do one on the authentication because I think that's, from the doctor standpoint, probably the most important as it hits workflow. But just make sure each one of these points is well addressed by whatever system that you are looking into. And, refer back to this slide if you have any questions as you're doing your due diligence with different products and different systems.
Okay, and as we just heard from Sean, authentication is obviously something very, very important. Aaron, can you tell us a little bit about what authentication modalities the DEA allows for EPCS?
Yeah, and so take a look at this slide right here. Again, as Sean said, this will be available to you all, but this is it right here. I mean, something you are, something you have, and then something you know, right? And some of these solutions work for you, some of them don't. Make sure you have a solution that and a vendor that you can partner with to employ a multitude of these in whatever form factor is appropriate for your workflow of your hospital, and you should be good to go. Sean, anything you want to add to that?
Yeah, just so the DEA is very specific. You need 2 of these at the time when you authenticate the order. So the common questions are, well, I already logged into my EMR. Is that acceptable? You can't use what you already used to log in. You can re-enter your password. It can be the same AD password. That's fine. But you have to now authenticate again. 2 factors of authentication, 2 of these 3, right now at the time when you order that controlled substance. That's a crucial point. Another common question is, can you batch them? So the answer is that you can batch them for one patient. In other words, I could write Xanax and Percocet and a number of other medications for one patient, and I could authenticate now, 2 factors now to authenticate that order all at the same time. I could not do that for 3 patients at once. That's a key point. So in the workflow, you have to go into a separate patient. At the end of that patient order, you would then authenticate this order with 2 factors. Then you'd have to go to a separate patient and complete that one, just so we're clear. Just to cut to the chase with what most provider systems choose, most places the large majority are choosing a soft token on a phone, a one-time PIN token. It generates a 6-digit number that you type in, or you can have a push token where it generates it on your app and you actually just get a banner notification. You hit agree or disagree with that notification, so you don't have to open up the app, look at the number, and type it in. Or we have something called a hands-free version, which uses low-energy Bluetooth. It will automatically generate that 6-digit number on your smart device and populate it back via a secure, special low-energy Bluetooth channel back to whatever machine you're prescribing on. And that is really kind of almost nirvana for the docs and nurse prescribers, because it happens in less than a second. And the phone can be in their pocket and completely hands-free. It can be locked. As long as Bluetooth is enabled, it will reach out, find that token, and automatically put it back into the system. And then, as we talked about, many places will put fingerprint readers on the most high-traffic areas. And a password, of course, can work.
Okay, so the good news is that the technology is not just a dream or a potential. It actually has been deployed, and it is paying benefits. Aaron, could you tell us a little bit about some of the benefits that actual hospitals have achieved after implementing EPCS?
Yeah, so I'll give you 2 quick examples. Number one, obviously, that was very near and dear to me, was meaningful use and making sure that you could really meet those e-prescribing rates so that you could collect maximum dollars for attestation. So we saw Worcester Community Hospital saw a 3x increase for meaningful use e-prescribing rates. And then we also saw another example here with Champlain Valley Physicians Hospital, who actually reduced their paper prescriptions by 84% by going with EPCS. So there's a number of other ones. Sean, do you know of a couple maybe?
Yeah, I mean, you can see up here Methodist Health System had an 85% increase in e-prescription rates. And then Health East Care System, their nursing staff saves up to 40 hours per day, and clinicians overall save 500 hours per month. You know, as a doctor, we always hear about the time savings, which is definitely important. It's also about not breaking someone's thought process and allowing them just to focus on patient care. Look, patients really like this. They like the fact that the prescription can be routed directly to the pharmacy. They don't have to go while they're in pain and wait for 40 minutes while a pharmacist fills their medication. It aggravates them that they can get their antibiotic prescription automatically sent, but they have to wait for their pain pill. So the bottom line is that a transparent and automated and really effective electronic prescription system makes it easier for people who legitimately need these medications to get them, and it makes it easier for doctors trying to get it to them. It makes it harder for people who are trying to divert and abuse these medications. To me, as a doctor, that's the bottom line.
Great. What we want to do now in the very short amount of time that we have left is just handle 1 or 2 questions from our audience. We've got a couple of really good ones. Our first question is, when identity proofing does credentialing, does the credentialing office need to store picture ID that is provided to identity proof?
You do not have to. We just have a checkbox, and a lot of places will actually put the number of the particular ID they looked at. We have a checkbox that has a host of different options like driver's license or, hospital ID and the different IDs that are allowed. That is sufficient for DEA compliance. Some places actually also put in the actual number of that license and things like that. You're not required to store a picture of that ID.
Okay, next question. How long does a typical healthcare organization typically take to stand up and deploy electronic prescribing of controlled substances?
It really depends on the system they use to deploy it and their own resources, their size and complexity. It's usually on the order of several months. It can be up to 6 months, but really the mostly the rate limiting step, as Aaron said, if you do your homework ahead of time, for example, with our system, a lot of time it's actually the same software a lot of places already have installed for another reason, for single sign-on. So it's the same software The hardware plugins are easy. It's just a matter really of enrolling providers. So I would say that far and away the biggest thing is if you got to spend time up front sussing out all these issues and actually doing your homework. Once you actually make the decision to go live, if you've done that properly, it's all about how fast you enroll the most number of people. And when you follow recommended best practices, it actually can happen in weeks to a month, where you just go around and you on a regular cadence, you go to their conferences. You can get 60 or 70 or even 80, 90% of your clinicians just by going to them, and then there's a few stragglers you can pick up separately after. And I can't emphasize enough, it's not one person in the credentialing office, it's 10 or 5 people across your system given administrative access with laptops who go cruising around and are able to do this very effectively.
And to give you some reference, in a previous life, I implemented it for my EDs, and I had a couple of hundred docs. And it took me about 3.5 months to get everybody enrolled, show them, train them, work with them, and even get the doctors that came off and on rotation, and took a few weeks off in between. So your average miles and distance may vary by hospital system, but for me it was a couple of months. So
great. Well, that does conclude our program for today. I want to, first of all, thank our speakers, Dr. Sean Kelly and Aaron Meary, for their presentation and for their discussion and insight into this valuable topic. Again, I want to acknowledge and thank Imprivata for sponsoring this program. We really appreciate their support. And last and certainly not least, we want to thank all of you who did take the time to attend today. We do appreciate your taking time out of your busy days to spend an hour with us, and we hope and trust that you got a lot of really good insight and have some specific ideas on what you can do next on this really important solutions area. So on behalf of Health Data Management and Imprivata, thank you again for joining us. Please join us for a future web seminar. I'm Mike Perkowski, your moderator. Thank you, everybody. Have a great day.